A 19-year-old Caucasian woman was referred to our clinic for evaluation of amenorrhea. This was an unusually late presentation for the investigation of primary amenorrhea. She had been investigated for thyroid dysfunction as the presumed cause of her amenorrhea at the age of 14 years. Her serum thyroid hormone levels were normal at the time, with thyroid stimulating hormone level of 1.4 milli-international units per liter, the normal range of 0.4 to 4.2 milli-international units per liter, and free thyroxine level of 14.6 picomoles per liter, with a normal range of 12 to 2.4 picomoles per liter, and no further investigation was undertaken. There was no family history of thyroid cancer. We observed informed consent from our patient for diagnostic procedures and treatment, as well as consent for inclusion of her data in an anonymized scientific report. A physical examination showed that development of sexual characteristics was not entirely normal, although the development of secondary sexual characteristics was normal. Investigations included abdominal and pelvic ultrasonography and magnetic resonance imaging. Type 1 Mayer-Rokitansky-Kuster-Hauser syndrome was suspected because of the total absence of the uterus and fallopian tubes. She had a vaginal remnant measuring of 1.8 centimeters in length. Both ovaries were normal and no other structural abnormalities were found. Examination of the thyroid gland showed enlargement with a mobile 2.3 centimeters diameter, solid nodule in the left lobe. There were multiple mobile left lateral cervical lymph nodes with a maximum diameter of 1 centimeter. Thyroid function testing showed normal serum levels of thyroid stimulating hormone of 1.8 milli-international units per liter and anti-thyroid peroxidase antibody, which was less than 34 milli-international units per liter. Thyroid ultrasonography showed a hypoechoic left thyroid nodule with increased central vascularity. According to the current guidelines for evaluation of thyroid nodules, fine needle aspiration biopsy was indicated. The fine needle aspiration biopsy showed high cellularity in the nodule, and the cytological examination showed follicular lesions that were classified as Thy3 according to the latest classification system. Technetium 99M, pertechnetate thyroid scintigraphy, which was 185 megabecquerel, showed a nodule in the left lobe with no metabolic activity. It was a cold nodule. The combination of clinical features, cytological examination findings, and imaging findings led to a diagnostic of nodular goiter, highly suspicious for malignancy. She was referred to our surgical department for total thyroidectomy with selective lymph node dissection. Pathological examination of the surgical specimen confirmed a 2.1 centimeter diameter papillary thyroid carcinoma in the left lobe with invasion of the thyroid capsule. 3 of the 16 removed lymph nodes were positive for cancer. The cancer was classified as stage 1 T2M1 MX according to the American Joint Committee on Cancer Union International Country Lay Cancer Staging System, 7th edition.